Good afternoon, everyone. On behalf of Tanenbaum, I would like to welcome and thank you all for joining today's conversation about LGBTQ patient care and religion. My name is Madeline Frankel, and I am the Healthcare Program Associate here at Tanenbaum, and I will be moderating today's discussion. We are the Tanenbaum Center for Interreligious Understanding, and our mission is to promote justice and build respect for religious difference. And in our healthcare program, we collaborate with institutions and healthcare providers to better recognize where religion comes up in medical decision-making and accommodate patients of all faith backgrounds and none. Today's conversation will focus on dismantling the idea that religious and LGBTQ identities don't belong together, and we will explore how this false narrative has made its way into our healthcare settings and ways to address it. And I am thrilled to introduce our panel of experts who will just provide a wealth of knowledge during today's conversation, starting with Dr. Joy Juro. And if each of our panelists just want to give a wave once I give them a shout out. So Dr. Joy Juro uses she, her pronouns and is a psychologist who began her career at the University of Pittsburgh Medical Center 15 years ago. During her time at UPMC, she has worked as the leader of patient relations at UPMC Children's and as the manager of LGBTQIA+ health at UPMC. She's led a team that improved UPMC's participation in the Human Rights Campaign's Healthcare Equity Index, and Dr. Gero currently serves as the Director of Population Health and Improvement for UPMC. Next, I'd like to introduce Professor Rusi Jaspal. Dr. Jaspal uses he, him pronouns and is the Pro-Vice Chancellor of the Research and Knowledge Exchange and a professor of psychology at the University of Brighton in the United Kingdom. He's a chartered psychologist and holds fellowships at the British Psychological Society, the Royal Society of Arts, and the Higher Education Academy. Professor Jaspal has conducted extensive research into the psychological well-being among gay men, the management of identities and conflict, national identity, prejudice and discrimination, and public understanding of science, technology, and medicine. Next, I would like to introduce Mordechai Levovitz. Mordechai uses he and she pronouns and is the founder and clinical director of JQY, a national nonprofit supporting LGBTQ youth from Orthodox, Hasidic, and Sephardi communities. In his tenure, he pioneered projects like JQY Teen Drop-In Center, the Orthodox Mental Health Conference on Sexuality, and the It Gets Better video for Orthodox queer Jews, and the Yeshiva University Gay Panel. Mordechai ran a private social work practice for child transgender care and worked at the youth program of the Manhattan LGBTQ Center. And finally, I would like to introduce Dr. Christine Rodriguez. Dr. Rodriguez uses she and they pronouns. Dr. Rodriguez is a family nurse practitioner with a strong commitment to providing inclusive, high-quality care for the LGBTQIA+ community. Her research interests are gender-affirming hormone therapy for gender-diverse folks, gender-affirming surgeries, sexual health, and the intersectionality of religion and spirituality and LGBTQIA+ identities. She serves as lecturer and the director of the simulation unit at Yale School of Nursing. And with that, we can jump right into our conversation. So here is how today is going to work. Each of our panelists have received a list of discussion questions. So I will pose a question to a specific panelist and give them the opportunity to answer. However, everyone will have the chance to share their feedback and answer all of our questions. So with that, I'm going to start with Dr. Rodriguez. Dr. Rodriguez, can you describe how your work dismantles the idea that being religious and providing quality LGBTQ patient care are opposing concepts?
Definitely, yeah. Thank you, Madeline, for the wonderful introductions of all of us. And yeah, really thankful to be here and kind of share my experiences. And I'll use my I statements, kind of speaking from my experience. So yeah, my work dismantles it. It's really interesting to see the history of where nursing kind of came from, as well as some of these healthcare professions. And it was rooted on this holistic aspect of care. And for me, that was one of the journeys that I first noticed is before most of colleagues in the healthcare professions were attending these fields, they were actually going into seminary because they wanted to take care of the whole person. And for me, it was a really interesting journey for me. And I battled that. And I said, you know, I understand coming from a strong religious background. So I came from a Pentecostal faith. And it was really hard managing that aspect, as well as having this kind of affinity for science and understanding what that world was. And it was a part of my life. And I always explain that always to my patients and people who I interact with. It's an intersection. So I can't negate that aspect of my life. And that's a part of me. So I always kind of show that and discuss that, especially with the work that I do. I often use my title of that Master of Divinity because it gives the opportunity for someone to recognize it and then say, well, wait a second, I think you might have gone to seminary school. Can I ask you a question and how that pertains to my health? And then that's the beauty of it, is that intersection to be able to discuss with the individuals that we encounter and have honest dialogues regarding their concerns and what that may look like specifically for them. So it's all about meeting people right where they are, having those honest dialogue conversations, because we all come from various backgrounds, different lived experiences, and hold a ton of different identities, especially with those intersections. So definitely for me, it was a journey. And it took some time to kind of say, well, is this right? Is this isn't right? And you're hearing a lot of different things from different communities. And it wasn't until I finally had those honest, open dialogue conversations with people who said, no, this is something that's a part of your life and we should acknowledge it, validate it, and know it as a valid experience. So.
Thank you for sharing. Would anyone else like to jump in on that?
Yes, thank you. I'd like to say a few words about that as well. So I'd like to just make 2 points really in terms of how my own works sought to dismantle this idea. I think the first thing to bear in mind is that we often, as human beings, we sort of see people through one lens, through the lens of just one identity. So people are sort of categorized as being either LGBT, or they're categorized in terms of their religious faith. But I think the key point to bear in mind is that we all have multiple identities. Our identities intersect. We're never just one thing, you know, and that's what makes us distinctive and human and interesting. You know, that's a really important point to bear in mind. And just related to that, sometimes within healthcare contexts, practitioners may feel actually quite hesitant about engaging with people because of assumptions that they may have about them because of either their sexual identity or because of their presumed religious identity and so on. They may feel very uneasy about engaging with them, and therefore that may affect the quality of the care that they provide and the satisfaction of the patient, you know, with that care. So I think also it's about raising awareness and getting people to be aware of their biases as well, aware of stereotypes, because these are very commonplace things that do really affect people's experience of healthcare.
Absolutely. You both bring up really excellent points of meeting patients where they're at, recognizing biases, and also recognizing multiple identities among patients. And really, when I think of all of those concepts, it really brings together the idea of culturally competent care. And I think a lot about in media today, there is this really perpetuated narrative that LGBTQ identities and religious identities can't exist together. So would anyone like to speak on where they think this narrative is rooted in and how it manifests in healthcare settings? Mordechai, I think you're muted. Hold on, let me unmute you.
Classic. No, just so I fit every single stereotype. Of course, so let me start muted. I think I love the idea of really kind of couching everything in I statements, because it's not only the way to answer the question, it's also kind of the answer to the question. The idea that that everyone's experience of the world, including their strong opinions and beliefs, are so rooted in the haphazardness of their existence, right? The fact that they happen to be born to this family, they happen to be born in this demographic, they happen to be born in this part of the world, and but for that they may believe different things, right? So kind of really rooting and that understanding to the way we approach almost all strong beliefs and religions, and saying, you know, I don't, perhaps I would feel the same way as you, as if I had the same upbringing, or if I had the same trauma, or if I had, you know, the same challenges or opportunities. And that I find is so often a great bridge, because it's mutually validating. It validates the religious person who may be in healthcare. If this is if the scenario we're talking about, if the religious person is the healthcare provider, it can also validate their beliefs, their existence, their history. At the same time, obviously, it can validate the patient's experience. So it's a kind of an empathy-based approach, and a humility-based approach, and often. It's, you know, religion, humility plays such an important role in nearly all religions. It would be nice if humility would also play a role in the medical field. I feel that's a particular area where I think religion can have a wonderful effect on the field of medicine and healthcare. This idea of humility, and obviously gratitude and graciousness, but which I think are connected too. So like the other panelists said, finding the intersections, if you look for them, actually are not, you know, they're quite clear when they come out. And there are so many areas where these two identities and these two kind of backgrounds can build on each other and complement each other, that yes, there may be areas of conflict, but like someone mentioned, we hold conflicts within ourselves. So the fact that we conflict with other people shouldn't be that catastrophic.
Yeah. Go ahead, Rusi.
Yeah, I think because your question was really, I think it's a really important one about why this narrative has taken hold in public consciousness. And I think we also have to recognize that within, so my research has focused largely on gay Muslims, but I think what I'm about to say applies to many different faith groups. Often leaders within these groups, they have a great deal of power in terms of shaping the way in which members of their communities think about the links between sexuality, sexual identity, and religion. And if they disseminate a very sort of stigmatizing narrative that suggests that these two identities are completely incompatible, that it's impossible to be gay and Muslim, then often people will internalize those ideas. And what I found is that sometimes there is a reluctance to critique those sorts of ideas that are often unsubstantiated. They're not really grounded in Holy Scripture. They are just based on cultural views, if you will. And I think that's something that we have to think about in terms of challenging this narrative. We have to think about campaigns that actually engage with communities and that work with faith leaders, so that we can have a more proactively positive, accommodating kind of narrative. And I think that would then trickle down into various different spheres of life, including in healthcare.
Absolutely. And that's a great point that you bring up, Rusi, in terms of, you know, faith leaders and the positions of power that they hold. At Tanenbaum, we were having a conversation yesterday in defining power as, you know, how quickly word becomes action. And if these messages are spread, they really get operationalized and implemented in our healthcare systems. And those people in leadership positions also very much have the power to shift that narrative and make our healthcare systems a more welcoming and inclusive place of LGBTQ identifying patients. Thank you. Okay, my next question I'm going to direct to Mordechai. And that is, how can we better support LGBTQ plus youth in relation to physical health, but perhaps more importantly, their mental health?
Sure. Well, I think that like most anything when dealing with adolescents, the first approach perhaps is always to listen. I think that teens just like to be and appreciate to be listened to, and to listen and hear and be interested, and you know, even like I'm as either a clinician or an advocate, we do come with an immense amount of knowledge and study and reading, and that's great and that's wonderful. Perhaps that's not the first way to approach young people, to kind of say, okay, well, teach me. And that always, I think, it starts productive conversations, and it builds a lot of trust. And also, like I said, it kind of puts that value of humility front and center. I think that it's particularly helpful when it comes to things like LGBTQ identities, which are so often, and I understand why, framed as definitions, when for at least the teens that I deal with, they don't see that there's a much more fluid sense of identity than definitions and boxes. And there's a kind of a frustration when they feel like someone comes in and like, I know exactly what a sapiosexual is. And that's what, like, you know, don't ask me about my identity, and ask me what it means to me, right? Like that's a special moment. And that's, again, I think that's really something that can work well with dealing with religious clinicians, right? Saying, well, really make it human focused, and like Rusi said about assumptions, you can throw a lot of assumptions out and start from the person. Tell me what you mean when you say that you're non-binary, right? I've read a little about non-binary, but I want to hear it from you. And the value is rooted not as much in kind of the general queer theory, but really rooted in my relationship with you, and that kind of interpersonal relationship. And that's a way where you can strengthen the relationship and make the patient really believe that this relationship is authentic. And then once you've developed an authentic relationship, mistakes often are made, right? Then it's not as scary to make mistakes, because we can't, I mean, I've been working for 20 years in the LGBTQ space, and there are some identities that I haven't heard of, or I sometimes confuse things, and that's okay too. But it's okay as long as you've developed the trust, as long as it's absolutely clear that my role here is to lift you, to advocate for you, and to make you feel like, again, this relationship is valued. And I think that if you do that, that you're going to be able to open the discussion to things that often are harder to speak about, particularly things like physical and medical issues, but also mental health issues, and obviously issues of trauma that perhaps are very difficult to speak about. Bedside manner requires us not to just ask questions that perhaps could be very traumatizing without that trust building first, right? You need to first value the human, understand that this is a safe space, understand what my role is here, and then slowly we can go to asking about trauma, which sometimes is necessary in a medical interaction, right? And certainly in a mental health interaction. So, building up that human relationship, I think, is a strength of religious people. So we can see it more as how can we use your strength as a person of faith to build up the interpersonal relationship, and then come from there. Hopefully that answers a little bit of the question.
Absolutely does. Thank you. And Dr. Juro, can I ask you to add to that, especially from what you've experienced at your time with UPMC Children's?
Yeah, I don't know if I can add to it, but because that was so perfect. I think that something that sticks out to me as well is that these are also, thinking about people's religious or faith traditions, as well as their identities around sexual orientation and gender identity. They're both areas in healthcare that we're not great at talking about, period. And so, times, I think in both domains of human experience, we just sort of adopted don't ask, don't tell. Like that's, you know, that's great. That's your personal private business. And I think when we're thinking about, queer youth particularly, we have to recognize that if we're not comfortable having those conversations amongst ourselves in healthcare, it'll be it creates a parallel process then when we're talking to younger patients, that this is something to be ashamed of or that they need to hide. And I really like what Mordechai said about, spending time listening and building that relationship and not making assumptions about, how that person is self-conceptualizing, right? But instead just allowing them to expose themselves to you. And I think that's incredibly important. We're lucky at Children's to have a gender and sexual development program that's been around for, I think, close to a decade. And, I think that's, it's lovely to see that. And for me, when I was coming back to work full time at UPMC after my doctoral work, I wanted to know that if I was going to work at Children's Hospital, they needed to be committed to caring for queer identified youth. And I think that's, one of the ways that I think we can, as healthcare professionals, continue to, move the narrative forward around, appropriate healthcare for queer identified youth is to, commit ourselves to supporting organizations that are doing that kind of work.
Thank you. And to build on that, I made a note of how it is tricky in healthcare to have those open conversations, and really a don't ask, don't tell policy has been adopted. So moving forward, what can not just providers, but administrations and hospital leadership teams do to reach out to the LGBTQ community and establish that relationship of trust?
Well, I think it's a two-phase. It's interesting because I was actually listening to most of the things that we were saying as panelists, and it kind of reminded me of an experience I had when I first walked as a chaplain onto the hospital unit. And our pastoral care director at the time said, "We're not here to change people. We're here to facilitate their journey." And those words were very powerful to me. And that's kind of the approach that I look at specifically on how we should look at healthcare. I favor what's called the participatory healthcare approach, where this isn't just a provider saying or a clinician saying, "Oh no, this is how things should be because this is what the textbook says." No, we work in collaboration with the patients that we encounter, and we facilitate their journey on what that looks like for them. When I work with gender diverse folks, one of the first things I say is, you're trans not because you're going to do hormones, not because you're going to do surgical interventions. You're trans because you are trans and you defined yourself as that. And I think that's powerful to hear because, as Mordechai is saying, you get this peer pressure of what defines what is gay, what defines what is trans within those youth years. And then you go into, and specifically when I worked in college healthcare settings, I'm left with these questions where students are like, well, no, you're supposed to have top surgery to be considered trans. And then you feel this pressure and it's like, no. You are trans because you are trans. You hold these identities because this is who you are. And we're just here to facilitate. So I think often having that approach of facilitation, participatory, working with the person that you're working hand in hand with goes a long way, as opposed to treating people like textbooks. People aren't textbooks, people are human beings. And we have to kind of understand that that approach, that textbook approach of everybody is not going to work for every single person.
That's an excellent point that you raised, Christine, especially in thinking of these clinical textbook definitions. You cannot clinically define somebody's identity. And I think of a lot of these legislative frameworks and policies that are, in the process of affecting our healthcare institutions that are denying the LGBTQ community of safe and medically necessary care. And really what it does, it clinically defines these identities among denying care. Does anyone else have any other thoughts on that question and ways to, move forward in reaching out to the LGBTQ community and extending a safe and welcoming care environment?
I just wanted to really say that I completely agree with absolutely everything that my co-panelists have said. I mean, I think it's a really, really important points. And I just wanted to kind of point to, just to illustrate how important the topic of trust actually is, to point to a couple of examples from some of the work that I've done. So I've done some work around the acceptability of pre-exposure prophylaxis PrEP for preventing HIV, which we know is extremely, extremely effective in preventing HIV. But what we find is that there's often a correlation between the nature of their healthcare experiences and their endorsement of PrEP. So, when people have really negative healthcare experiences, often because they feel discriminated against, they're less likely to endorse medical interventions because they think, well, I don't trust those guys. I don't trust anything that they have, any advice that they have to give me. And that has really long-term effects on health. During the pandemic, we found that ethnic minorities and religious minorities were more likely to get seriously ill with COVID, to be infected, but also much less likely to get vaccinated. Again, that's linked to historical injustices, committed against minority groups. So it's just so vitally important that we do find ways of building trust. And that trust has to be earned in the way in which Mordechai was saying. It has to be built. We have to invest in that. Now, sometimes some of my clinical colleagues will say, well, actually, we're really overworked. We don't have time to engage with patients in the way in which you're suggesting. But I would argue that it's really important that we do put in that time and effort into building rapport with patients, because it will have very long-term benefits, and we will really be able to change the direction, the sequence of events, in a very positive, proactive way.
I just, so let me just say too, that is 100% brilliant. Agree so much. And I think it pushes, I think, healthcare organizations to think about how are we not just building trust, but a colleague said this in a discussion we were in last week. How are we trustworthy? How do we show ourselves as being trustworthy? And I think there's not one way to do that for sure. I think that one of the things that we've tried to do in our health system is to go to communities and say, we don't know what you need, but we know, we might know what healthcare, like what good healthcare is, but we don't know what you need. And so, teach us about what you need. And those are new conversations for us to have. And I think sometimes they're difficult because, the traditional way that we deliver healthcare often suits a very white cis het, maybe even we could say like a Christian narrative, and it's not expansive around other intersectional identities, and it's hard for us to think about delivering healthcare then in a different way. So that's one of the ways that we've tried to be more trustworthy, is by saying teach us. But I think that's part of it, is we can't expect any underserved or marginalized population to suddenly trust us if we're not acting in a way that's trustworthy.
Yeah, if I can just add to that, I mean, it's a really important point. I often hear when I complain about the lack of, say, research into particular groups, I often hear, oh, that's a hard to reach population. And when you say hard to reach population, it kind of closes down the debate. It's like, well, that's too hard. Let's not even go there. I would argue that we've just not found the right methods for engaging effectively with those groups, but we need to continue to look for those. And I think the prime way of doing it is to work closely with those communities. And just to give you one example, say I talked a little bit about HIV research. One particular group that we have very little data on in the UK is trans-identified people, and in relation to their experience of living with HIV, but also the risk factors associated or that disproportionately affect people with a trans history. And, again, there's this idea of, oh, well, trans people don't engage with our clinical services. Well, it's sort of a bit of a chicken and egg situation. We have to engage, and we've got to, and that will be one way of establishing or beginning to establish trust, because we're demonstrating that you matter and your lives matter. And that's why we are working with you to support you.
I just want to build on that, because I think it's such an important point. I think that because we are now challenging clinicians to kind of spend that time building trust. And yes, there may be some very valid limitations on time, and I understand that. But that's why we can present language, affirming language, particularly pronouns when it comes to gender diverse people, but also language when it comes to identity, as tools and not rules. Because if you say, yes, if the goal is to build that interpersonal relationship and build the trust, the tools for that are listening to the language that this person uses. Use that person's language. Don't use your language to describe somebody. Listen to their language that they use so you can build trust. I mean, and it's not, just thinking even about my Jewish identity, right? Like, I would feel really weird if I went into some cafe or in my work and they started calling Jews Israelites, because that's not the language I use for myself on Jew. Now, it could be that maybe, sons of Judah or Israelites or whatnot are all maybe descriptions of Jews, but that's not the language I use. And if you want to build trust with me and me feel, and so I feel safe as a Jew in this space, as a minority and a Jew in this space, then use the listen first and use the language that I use. So, and that certainly applies to pronouns, because that's the name that I use, the same way that my name is Mordechai and not Joe. So please try to say Mordechai, even though it's hard. If I use they pronouns, it may be difficult and you may make a mistake, but don't call me Joe. Use the they pronoun. So, right, it's just, but seeing that as a tool and not a rule, I think is a way in, especially with clinicians that may be a little hesitant.
Thank you all for raising those excellent points. Another question that is coming into my head as we talk about this, Dr. Gero, you mentioned that really our healthcare system was not built for marginalized identities. And Dr. Jaspal, that our systems kind of categorize these folks as hard to reach populations. How do we go about making healthcare more accessible to marginalized identities, such as LGBTQIA identifying people?
Well, I'll just say a few words in relation to that, and then perhaps Joy will want to add some reflections as well. I think in my experience, I found that sometimes marginalized communities may have low levels of trust, and they may not feel very comfortable engaging with healthcare services. So I think there's a lot to do to build trust, as I've already said, but there's another area that I just want to kind of focus on, and that's HIV, which is obviously the area that I've worked in. But sometimes there can be very high levels of stigma within particular communities. And I think we can be quite creative in how we say take out, just as an example, HIV services or HIV testing services in really quite creative ways, so that it's framed not as exclusively just about HIV, but about health in general, and it's packaged as part of that broader package around health, so that we're able to to engage communities around the broader topic of health, but also then capitalize on the opportunity to talk about HIV. It's something that may not happen very much because of course HIV often involves discussions about sex, and that can be quite a stigmatized topic in general. It often involves discussions about homosexuality, which can also be a bit challenging for some communities as well. So I think looking at these very creative ways of engaging people around stigmatized topics is really quite important. And I think the same applies to mental health. Mental health carries a great deal of stigma, and that stigma can be really accentuated in some communities where there may be some, for instance, more traditional views, or there may be quite spiritually related views about what mental health is, or and what particularly what mental ill health might represent. So for instance, in some of the Muslim communities that I've worked in, often a mental ill health was linked to, say, demonic possession. And of course, you can imagine that people would really resist any discussions about mental health because they do not want to be categorized. in that sort of camp of possession, if you understand what I mean. So I think that, you know, we've got to have, it comes back to that point about listening, having an understanding of the communities, and then responding using the most effective tools that we have. And those tools will differ in accordance with time, space, context. It's about being quite creative.
I do have something to add to this because I think this is a really interesting discussion. And I also saw Lynn's comment on saying it's hard to teach how to develop trust using the person's language. It's helpful, but do you have other tools? So I'll start it kind of with twofold. The first one too is there's this use of binary language within our healthcare system. Intake forms have binary language, and that's not representative of the diverse communities that we serve. So there's certain times that you will enter a center, and I can speak on my experience. You know, I enter a center as a trans woman, and I look at this specifically, and if I see a form that says male or female, I automatically feel uncomfortable already there. And that's something that kind of already raises a red flag for me, because it's two things for me. The first one is safety, and the second is, am I going to be discriminated or affirmed in the setting, right? And that already creates turmoil for me. So I think that's the first aspect also, is this use of binary language that has been occurring within healthcare settings. The second part is, where does that originate from, right? So when we look at healthcare curriculums, you know, it's the amount of knowledge that's being infused regarding this content. Yes, it's increasing, but it has lacked significantly over the years. And because of that, we're seeing these trained ideals of thinking that things should work this way, things should be that way. And we can infuse this care within all aspects of all disciplines within the curriculum. And I often kind of talk about this because it's so important. Sometimes it's just grouped on a slide saying that this is HIV care and this is what we need to know about this population. And it's not just HIV work, right? It's everything involved. How do we do a sensitive exam on individuals who hold different identities, and what does that look like? So the training starts first with those curriculums, adapting the curriculums, making sure that they meet the needs of the communities that we serve. And then with that, when we look at these healthcare settings specifically, what are we doing to provide inclusive environment? What do waiting rooms look like? Do I see pictures of people who look like me? Do I see other things throughout the community where they're saying, how are you doing this process of going back and forth? Do your electronic health records have a space to denote pronouns? Does it have a two-step process where we're asking both sex assigned at birth and gender identity? So it's a lot of work that we still need to do. SOGI data is so important. And what I mean by SOGI data is sexual orientation, gender identity, gender expression data. So we need to collect that, and you could see it as clear as within the census. How do we even get an accurate amount of what these identities look like when they're not even listed within these census? So very, very difficult conversations to have. So I think it's language is one piece, it's education, that's training, those sensitivity trainings that should be happening annually. We're not experts. You know, the language continues to evolve, and there might be some terminologies that we may not be accustomed to. And we have to learn to be humble enough to say, okay, I need to learn more about that topic and immerse ourselves into that culture. And I think that's the aspect that sometimes we forget. It's a culture. And just like we need to understand language and everything, folklore, things about that culture, we need to immerse ourselves to also do that. Awesome, Lane. I'm glad that kind of helped out also. And I'm more than happy if any panelists also kind of want to hop on, because yeah, these are such important topics, and we're thankful to be here to kind of address them.
I think I'd also just add that, you know, I think that the great value of allyship should be emphasized. I know as a gay man who's faced quite subtle homophobia, what's really helped me and made me feel supported is when there's actually someone who's not gay or not LGBT who's saying, actually, you know, I'm going to stop you right there because what you've just said is quite homophobic. And I think it just creates an environment, a sort of a never okay environment, where people understand that the language that they're using is just not acceptable. And I think that applies for the various different groups within the very broad LGBTQ community. We've just got to support one another and build a culture where it's never acceptable to be discriminatory. And also, I think, to be quite aware that prejudice itself is changing and it's becoming so subtle. We talk now about microaggressions. You know, again, having faced that myself, I know that it's equally as painful as quite overt expressions. It's probably more painful because it's not readily noticed by people in the way in which an overt expression of prejudice might be. So I think that contributes to building quite an accepting culture when we start to really stick up for one another and to understand how this affects, because we ultimately undermine a harmonious environment where we permit any form of prejudice.
Thank you both for providing those comprehensive answers and what we can do to move forward, and, you know, what tools we can use. Another question that I have is about not only providing inclusive environments for LGBTQIA+ patients, but staff members. How can we encourage more folks to join healthcare spaces, either in administrative or clinical roles, and interact with LGBTQ+ patients? And what sort of impact does that have on the relationship?
I'll just say, something Christine said about SOGI data collection. This is, I think, a lot in lots of organizations, regardless of sort of the where, we're not really great at collecting that identity about the people that work at an organization either. So we're not really great at data collecting it for our patients. We're not really great at data collecting it. So it makes it difficult, because this is also an identity that, like, if you meet me and you see that, like, there's certain things that I signal to other people that I'm part of the LGBTQIA community, right? And sometimes people pick up on those signals and sometimes they don't. But I think that this is an identity that, unless I disclose it, people don't necessarily know. And so, I think one of the things that's important in order for healthcare organizations to better encourage diversity, equity, and inclusion in terms of how we hire and recruit people into healthcare is first just knowing who that's already a part of the organization as part of these communities, and that can be, I don't think that should be forced, right? There's lots of identities that we disclose at the beginning of a relationship with an organization. That's like, you can choose to say that you're a military veteran or not. You can choose to say that you have a disability or not. You don't have to do it. But if there's no opportunity to do it, then you can't then start to track and trend the data in the organization. It makes it difficult, I think, for organizations to think about how we recruit folks. So, I think that that's one of the ways. The other way I would just say is, I think it's about how we talk about who is, how do we elevate queer people who are part of organizations already, and make sure that their identities are being discussed as leaders, as healthcare providers. That is another way I think that helps, so I can say on a micro level, if I'm doing an interview with someone and I kind of pick up on perhaps they're somewhere under the rainbow with me, I intentionally will say some things in that interview to let them know that this is something that's, this is a place where that is held. In the same way that if I am interviewing someone who discloses that they're part of a non-dominant, faith tradition, that is also something that is respected at the organization. So I think making that space on a micro level is important, as well as kind of understanding it as a macro level from a data perspective.
I think that when you work at an organization, or when I would work in an organization, I'm very sensitive to the organizational culture of, is the specificity of my identity celebrated, or is there more of the pressure to conform, to be less what I'm specifically as, and more of this kind of group identity of just someone who works at this organization? So am I feeling, in terms of the way I would wear my hair, if I would decide to wear makeup, if I would decide to wear a certain earring, if I would decide to wear a shirt or a blouse or a necklace, or all of these things, I'm going to think about that in the morning when I get dressed. I'm like, what is celebrated, or what is respected at my place of work? And I think that we also have to be honest that we're moving in a culture away from one ideal into another. That for a long time, particularly in the 80s and the 90s, there was, especially in scientific and medical medical fields, there was the idea of, I don't see color, I don't see sexuality, I don't see gender, right? And we've moved, because we've listened, and we're like, wait a second, that actually doesn't make me feel good. Like, we've moved from that to where, no, that your color, your sexuality, your gender, what makes you unique is a value add. So I want to see it if you would be so gracious as to share it with me. With no pressure, of course, but if you would do that as a gift that you bring into the space, and to respect it as a gift. If you're in an organization where you feel that your specificity and all your colors, or all your eccentricities, all your wonderfulness are respected and celebrated, then you're more likely to be a beacon of representation, which will only help build trust, as we talked about before, the importance of building trust, because there are so many non-language cues that tell a patient when a patient needs, you're not alone, right? And it could be, and you never know when that could make the big difference. Certainly in the queer world, we have so many but also in the religious world, when we're talking about ethnicities and races, and it's not always language. Sometimes it's allowing someone to represent their humanity and the specificity of their humanity. And that's going to build a bridge. So we need places where if I have to question of, whether if I'm going to wear my earring and it's going to be too gay, like, no, they want me to wear my earring and be too gay, because too gay is going to be wonderful. It's bringing your gift into this environment.
Thank you. Incredibly well said, all of our panelists. And the next question that I have, and this will probably be our last because we're almost coming up on the hour, and I want to give our audience members a chance to ask their questions, but I want to focus a little bit more on the macro level. We've spoken a lot about, the micro care level, but any of you have any advice or suggestions for finding gender affirming care or trustworthy care providers in areas where it might be difficult to find comprehensive LGBTQ inclusive care?
Yeah, this one's a fun one. Lots of interesting statistics that have shown throughout. With my work with gender diverse folks, it's the data staggering. So the data that came out specifically with the 2015, which was published in 2016, which was the largest trans survey that was put out. The new data is going to come out hopefully sometime this year or next year, which will be really exciting to see. But what was seen in that data was that trans people are more likely to drive, they're 3 times more likely to drive 50 miles or more to receive trans competent care. And when you think of that type of data, that says a lot. And that's very resounding to the community and how access is not everywhere to be found. Now, there is a rise of what we're seeing in these telehealth platforms. And I think the pandemic, it has brought its losses, and it's also brought some positives to us within our communities from what we've seen. And one of them is this emergence of telehealth, and now this coding and how we're doing telehealth. And a lot of telehealth practices opening up in rural areas that are geared towards providing, care to these queer communities, which is so key. So areas that we wouldn't think of to have those access of services now are being served. The other aspect too for us to consider is there are tons of anti-legislation laws now that are popping up every single place. And what does this mean for the health inequities and the health disparities that already existed and now will be continued to be perpetuated? So it's one of those things that it's kind of like a two-edged sword, I say. We have to kind of keep being vocal about the things that we're doing at work. So those health bills that come out, we should be advocating, or we should be speaking about it and going against what things are saying. We should be looking at what type of groups are being represented within those healthcare bills. Recently, there was a healthcare bill that was passed here in Connecticut where tons of different community members were included, but they left out the Indigenous community and their representation and what it means to be Two-Spirit. And I think that's key. It's, yes, we don't have all the answers, but the inclusion of everyone can help us create that unified community that allows us to understand different perspectives, different views, and again, increases awareness for what we do. I wholeheartedly agree. I think, we really should be pushing, and the more awareness that we increase is great, which is really exciting. And just like Mordechai was saying, which was a really interesting point, we kind of navigate spaces sometimes and say, is this a space I can navigate, or is this a space I may not be able to navigate? And sometimes I look at it and I say, okay, this is a space I'm just going to pass. I'm not going to disclose my identity, and I'm going to go stealth, because as a trans woman of color, I know what those statistics look like for me, and my safety at that point takes priority. So it's tough one of those days trying to do it. And then there's sites that you might be celebrated for who you are. And that's exciting to see, because then guess what? You're bringing hope to someone else within the community that says, wait a second, if you're there, that means I can also make it there too. And that's inspiring. And that's what we want to do, is be able to kind of hold these positions in circles, hold that power, hold that privilege to be able to say, no, we exist in these type of circles also, and we're here. And I think that creates a great role model, great hope for our communities.
Yeah, one thing that I would add, and I'm sort of I'm saying this, but I'm sort of like it's like a humble brag too. So, but I think, you know, the ACA, you know, really pushed insurance companies to start covering some kind of gender affirming care. It's not as expansive as we probably like it to be in lots of places, and that sort of varies depending on the health plan. You know, I think that health insurance companies haven't done a great job of all the time of you know, helping then their trans members find care that, you know, that is covered, right? So a thing that we've done, and I think this, you know, I would suggest this is one best practice. It's not the only one, but we have a transgender member services line. So it's a specific member services line. So trans folks who are health plan members can call us, and then they're going to help them navigate. Like if they're in rural Pennsylvania and they have to travel further, right? Are there virtual appointments that are available to them as health plan members? Are there maybe someone that they don't know of, you know, who's a little bit closer? You know, that's not perfect. And I think there's nothing to say that that's what people have to do, but I think that, you know, we should start, you know, demanding not just of our healthcare delivery systems, but also of who's like paying for it, that they would help patients and members to navigate those systems better and more comprehensively.
Thank you both for answering. Those were excellent answers, and better recognizing where care is not necessarily accessible and what tools can be put in place to make it more accessible. And really, the telehealth world has kind of just revolutionized the way we think about care access. So we are wrapping up on our hour. So I want to leave these last few minutes for audience members to put any questions they might have in the chat box. So we'll give everyone a moment to do so. Okay, it doesn't look like we have any additional questions. So I will wrap up our conversation by first thanking all of our expert panelists today for sharing their expertise and their time. We are so grateful to have you join us and talk about such an important topic in both the faith and healthcare worlds. And I want to thank our audience members for your time and attention in tuning into today's conversation. If you feel that you learned something or would like to, well, I hope everyone learned something, but feel, you know, something significant that you are taking with you today and would like to host your own conscientious care conversation at your company or organization, or would like to sponsor a future conscientious care conversation, please reach out to healthcare@tanenbaum.org for more information on how to do that. And I think that going into our weekend, being together to learn and reflect is a great way to start. So I just want to thank you all again and say take care.
Thank you.
Thank you, everybody.
Thank you. Thank you. Humbled.
Bye.
All right. Bye, everyone.